It's time for the View in Your Mirror podcast. I'm Katie Harms, and along with Lisa Rubin, we help you check in and curate the best possible you and the best view in your mirror. We share tips, tricks, and strategies from our 35 plus years in our respective industries. We talk about your day from morning to night and everything in between. We share our uniqueness, relish in our shared experiences. Along the way, we share conversation with fabulous people who give us their own thought-provoking insights. So come along as we help you hone the best view in your mirror.
Computer wasn't working. So here we are.
Yeah.
I believe that this all happened
For a
because
reason.
we're supposed to be
Together.
doing this very important podcast.
Yes.
You had a birthday. I had a birthday.
I haven't taken you for your birthday yet. Let's be
No,
clear on that.
there. Well, you haven't, and it might be into August at the rate that we're going.
I know it's bothering me.
Well, don't let it, because life is good.
Okay.
Life is good. We're talking about Rustica. We might as well talk about the fact that they are our presenting sponsor, and we love them so much. We're doing other things. So,
But I did think when I was having my hangry meltdown moment, and I did think, do I swing by and get a cookie? And I thought that's a really good idea, bad idea, because if I just eat a cookie without eating, then my brain
sugar
is going to
spike
work.
and all that. Yeah, not good.
So I didn't do it.
Okay, I'm proud of you. Let's talk about Rustica really quickly.
I did. Their cookie.
Their Minneapolis location. We got to get to their Minneapolis location. Can we set that as a date?
It can be your
They're down
birthday.
Minneapolis in August. We'll do it. Downtown Minneapolis, Edina in Southdale Mall, Wyzetta, and the original Bidet Makaska.
Yes. And then also very quickly, I also want to give a huge shout out for another sponsor of ours, Sweet Ivy.
Can I just finish Rustica? rusticabakery.com?
Yes, you can. Sorry.
Okay. All right. And Sweet Ivy. Yes.
So, Katie, I did a seminar last week for a corporation, and I went into Sweet Ivy and I picked out all clothes from there to show. And it was wonderful, fabulous. And the magic pants, I call magic pants. They're really not called magic pants, but now that's what everyone in the store calls them. I'm telling you, like the women at this seminar, I made one person try them on and they're like, oh my God, magic pants.
Yes.
So let me give a plug to Sweet Ivy, who's really the only store that carries a large amount of Lissy or Lissay magic pants, Lysse pants, and she carries them and they're awesome.
I love it. I love it. And as long as we might as well wrap up our sponsorship talk and talk about Beam Light Therapy in St. Louis Park. By the way, I too was in Sweet Ivy, bought the cutest pair of shoes. And I think I probably sent 5 people at least in.
Did you buy the same pair of shoes I bought?
I don't know. We'll have to compare afterwards.
Okay.
We're not going to.
We don't have time to talk about shoes.
I want to get to Mindy. I so want to get
I
to
know.
Mindy.
I know. You're cutting me off.
Thumper.
Yeah.
Wanting to get to, but Beam Light Therapy, we also want to give some love to. You know, I walked in skeptical to them and I walked out a convert, and it's red light, infrared, skin inflammation, recovery, sleep, feeling better in your whole body, right?
Yep.
And you have nothing to lose and everything to gain. So if you want, go to theviewinyourmirror.com and there is a special offer for them on our website. So there you go. Sweet Ivy. Okay. Now, why we keep talking about MIDI and why are we talking to Dr. Mindy Goldman again? Okay. We've talked about MIDI Health a lot across the first episode, other episodes. Actually, we had their founder on a year ago. We want to be clear about why we're doing this, right? The information about women's hormonal health is finally being corrected. So what the science actually says about estrogen, about the Women's Health Initiative, about heart health, brain health is getting out into the world correctly. And women are waking up to what they've been denied, quite frankly. And this is good and it's long overdue, but there's a problem with this, right? The floodgates are opening. And there's no way our local physicians can keep up, even if they're doing the training, and a lot of them are, right? They're seeing 40 patients a day. They received 8 hours of menopause training in their entire residency. So they have to become specialists and do the extra work, which they're doing. The demand for knowledgeable, attentive care is surging, and the system is not built to absorb it right now. And that's the fact that many women don't know how to start the conversation with their doctor. Some are unsure. Some have tried and been dismissed. Some are even a little scared of approaching a physician they've trusted for years with something this personal, and so they stay stuck. And so this is the gap that MIDI was built to fill, not to replace your physician, but to work alongside her, to be the place women can go when the system cannot move fast enough. And the fact that their chief clinical officer gave 3 hours of her time to our podcast, not because of our numbers, but because of our women. The women that listen to us tell you exactly who MIDI is. They are interested in building it and building it right. So we've received so many questions ahead of this episode that we can't possibly get to them all, but we're going to do our best. But the point is, every woman asking is an individual. Her history, her body, her risk profile, none of it is the same as the woman next to her, right, Lisa? You and I, as similar as we are
different.
we are. So what we can
I
do,
am a lot shorter than you.
what we can do is we can open the doors. What MIDI does is they have real conversations built around the specific person, not the protocol, and they can help you walk through that door with them. That's why we keep coming back to them and where you should go when this episode ends, MIDI Health. And
Joinmidi.com.
Joinmidi.com, thank you, is their website. So let's welcome back Dr. Mindy Goldman.
Okay, so
Dr. Mindy, part 1 opened important doors for us, and we need to go deeper on estrogen, cancer risk, who benefits from HRT, and we also want more on testosterone, specifically in a fuller conversation on GLP-1 and cardiac health. So we're so excited. Just a little bit of information, but about what's going on in most women's minds on an everyday basis, right? So, but you said something in part 1 that really kind of stopped us cold. The estrogen only arm of the WHI showed lower breast cancer risk, and that finding was never publicized the way the original headline was. Why? I guess why is not the important, but it certainly cost women a lot. Why was that decision made, and how is it being corrected?
I think the decision about publication of the WHI, there's a big kind of why was that? Why was a press announcement made before publication in a major medical journal? And why were all of the researchers that were involved in the WHI not made aware of the press conference until the very last minute? So there's a lot of sort of whys that I can't answer. But when the initial arm of the study was stopped, that was in 2002. And that is when the alarm bells went off that hormone therapy increases the risk of breast cancer. The estrogen-only arm of the study wasn't stopped until 2005. But you had 3 years during that time period where women were already all calling their physicians saying, get me off these hormones, they must cause breast cancer. Lots of confusion in the medical community. And so when they stopped that arm of the study, I think there was already so much publicity about hormones and so much concern that the benefits, that the fact that they saw a lower risk of breast cancer just never really hit the press in the same way. There was too much negative information that was already circulating about hormone therapy. In terms of how are things being corrected, really it's removal of the black box warning that is correcting all of this. I think there's still a lot of information that we need to learn. There are still plenty of studies that need to be done. For example, we know that the risk of breast cancer was decreased with the formulation of estrogen that was studied in the WHI in the treatment group versus placebo. That was oral conjugated equine estrogen. The trade name was Premarin. Nowadays, when we give women hormones, we tend to use bioidentical formulations. These are formulations that are more like what our own body produces. Our bodies produce estradiol. So we have these bioidentical estradiol commercial formulations that are available that we use in hormone therapy. We do not know if bioidentical estradiol is as protective for the breast as oral conjugated estrogen, the old Premarin. That is still an unknown. We are extrapolating the data from the WHI and saying estrogen prevents breast cancer in the general population, but we don't know if the current formulations we are using nowadays truly are as preventative. That's just one example of many where we need more studies. Current formulations of combination estrogen and progesterone. We say that those seem to be more breast neutral and that there's not large randomized controlled trials, but there are these meta-analyses of many, many trials that included more than 85,000 women that say up until 5 years of use, there doesn't seem to be an increased risk of breast cancer with these current bioidentical formulations of estrogen and bioidentical progesterone. Another gap we don't know is, well, if those seem to be more breast neutral, what about in people who are high risk for breast cancer? They have a family history. They have a genetic mutation. They have breast atypia. Is it safer to use these formulations in women who are at high risk? This is another gap in the literature. I just tell you these to say, these as 2 points to say, there are so many areas that we still need to get more information. But removal of the black box warning and stopping the fear that women had is the start.
So I have a question regarding the estrogen, the bioidentical, and what you're talking about now. When did that start getting manufactured? Like, who came up with the fact that, if we did this, it might be better? Was that right after 2005 or?
Good question. I actually don't know when bioidentical estradiol came on the market. I'd have to look that up for you. There were a lot of changes that did happen after the WHI. In the WHI, they studied an oral form of estrogen. And we know when you use a non-oral form of a medicine and you bypass first metabolism through the liver, that it affects clotting profiles differently. And it also, the side effect profile is different. Oftentimes people may tolerate a patch or a gel differently than they tolerate an oral pill.
When you say it affects them differently, it affects them better?
For many people, yes. For many people who have side effects, they can be minimized by using a non-oral formulation. Again, that's not across the board, but for some people. The big thing is the clot risk. So there have been studies that have shown that non-oral formulations that bypass the liver impact clotting profiles in a different way and do not seem to increase the risk of blood clots. So what did start happening since the WHI, at least in the past 20 years, is an increasing knowledge that different formulations of hormones have different risks. And first-line therapy became, and I can't tell you exactly which year it was, but over the years, recommendations have changed to shift towards suggesting first-line being a non-oral formulation of estrogen because it has a better safety profile as it pertains to clots.
Okay. And you're going to take each single person that you talk to on a case-by-case basis, knowing all of this information. But for example, a 2-time breast cancer survivor that's had a hysterectomy, no ovaries, the answer to whether she can take estrogen is going to be very nuanced based on her specifically, correct?
Exactly. That is a complicated question. So let's look at what do large guiding organizations say about the use of hormones in the setting of breast cancer, and then let's go into some of the nuances. So one thing to realize is that breast cancer is not all the same, and hormones are not all the same. There are many different types and formulations of hormones, Each one may have somewhat different risks. We just talked about oral and patches affect clotting profiles differently. We just talked about the fact that we know the oral conjugated equine estrogen that was studied in the WHI is the formulation that is most protective for the breast. And we don't know if bioidentical estradiol is as protective for the breast. We know that the formulation of progestogen that was studied in the WHI, which was a synthetic progestin called medroxyprogesterone acetate, the trade name was Provera. That was the formulation that has been shown to be associated with an increased risk of breast cancer in many studies. We know that bioidentical formulations of progesterone are thought to be more breast neutral, so those are differential effects. However, if you have abnormal bleeding, you want a really strong progestogen that stabilizes the lining of the uterus, and that's where you want to use the synthetic progestin that was studied in the WHI. So to your question, yes, very much. Every single person needs to be individualized because people come in with different personal history, different family history, different skin sensitivities, different reasons why they want hormones, different concerns, and you need to take into consideration all of those issues when you're coming up with a treatment plan that is right for them. Going back to breast cancer. When I said not all breast cancer is alike, if you have a hormone-negative breast cancer and you have been free of disease for a period of time, typically at 5 years, we will say you are cured of that cancer. That doesn't mean you couldn't get a cancer in the future, but you are cured of that cancer. And we have no evidence that the use of menopausal hormone therapy will increase the risk of recurrence of a hormone-negative breast cancer. So that is a situation where you could offer hormone therapy. Again, just like we talked about, you need to individualize what type you're going to offer, but you could offer hormone therapy. Hormone-positive disease. All of the large guiding organizations in this country still say that non-hormonal options should be used first line for women with a history of hormone-positive breast cancer. There are gaps in the literature. The gaps in the literature are, what do the studies show that have looked at whether the use of hormone therapy increases the risk of recurrence in hormone-positive disease? So there have been large randomized controlled trials that have looked at that, and they showed conflicting results. The two big ones are called Habits and Stockholm. One showed a higher risk of recurrence of breast cancer. One showed no increased risk of breast cancer. The problem is those two studies used the older formulations of hormones that were used in the WHI primarily, and not current formulations, particularly with bioidentical progesterone. So the gaps in the literature are studies looking at current formulations of hormones that are used nowadays in women with prior hormone-positive breast cancer. Should we be doing shared decision-making with patients who have had breast cancer in the past, really suffering, telling them what we know and what we don't know? Absolutely. My general approach is I still will offer non-hormonal therapies. If they failed, I want to understand the severity of their symptoms, look at them as a whole, and talk to them about why their reasons are that they want to use hormones. I'm going to counsel someone different who had breast cancer, completed all their recommended treatment with a drug like tamoxifen or an aromatase inhibitor, has been free of disease and doing well, even though I know you can sometimes see late risk of recurrence, but I'm going to counsel that patient differently than someone who had breast cancer a few years ago who, let's say, chose not to do the recommended therapy. Those recommended therapies like tamoxifen and aromatase inhibitors decrease the risk of recurrence. And if they chose not to do that, maybe if they take hormones, their risk may be greater. Again, this is something we don't know, but I do not think that hormone therapy is right for every single person who has previously had breast cancer, but I think the time has come that we should be doing conversations and a deeper dive in individualizing how we counsel people.
So I have a couple questions regarding that. If somebody is a breast cancer survivor and she had hormone positive breast cancer, and she did take tamoxifen and some of the drugs, went through her treatments that she was supposed to take, and let's say it's been 10 years, right? And she's hearing all of this information, she still doesn't feel great. If she would choose to try hormones, is that something MIDI would say, okay, it's up to you. You can take the risk. That's on you. Or is it something that as a physician or as a provider, you're not willing to agree
Yep.
to?
That's a great question. And the answer is that we will have a shared decision-making conversation with the patient like that, tell them what we know, what we don't know, and help them make a decision whether that's right for them and potentially prescribe. What I will tell you is many people like that who have had breast cancer a long time ago may also have been menopausal for a long time. And I think on the first episode we did, we talked a lot about who are good candidates for using hormones and the fact that most women in the perimenopause and menopause are good candidates for hormone therapy. But there is what's called the timing hypothesis. And the timing hypothesis says that the risks and benefits of hormones differ depending on the age of the patient and the years since menopause. And if you initiate hormones within 10 years of menopause, so from the last menstrual period or under age 60, the benefits are thought to outweigh the risks, and specifically those benefits pertain to cardiovascular disease. And the theory is that estrogen changes coronary vessels in a way that makes them less sticky. Platelets and all of the factors that form plaques don't form. But if you wait 10 years, someone may already have plaques in their vessels. So when I have a breast cancer patient who is free of disease for 10 years, I want to look at their whole health history. I want to know, how old are they? Are they older than 60? They've been off hormones for many years, probably because they had breast cancer. Are they beyond that timing hypothesis window? And what are their cardiovascular risks? What are their lipids? What's their blood sugar, their hemoglobin A1C? What's their blood pressure? Do they smoke? I may recommend supplemental testing like a CT calcium score to look at their coronary vessels to see if they have plaque. So it's not just a straightforward decision of you had prior breast cancer, you're free of disease, I want to take hormones. It's let's look at you as a whole person and look at all of your risks. If you are low risk for cardiovascular disease, you have been free of disease for a period of time, you understand the gaps in the literature, yes, we are willing to offer hormone therapy.
So I have a side question for a client of mine, and she's listened to the podcast. But one of the things, she went to her physician, she lives in Chicago, and she only has one kidney. And her OB said that she can't go on HRT because she only has one kidney. And I'm like, oh, that's one I haven't heard before. So I'm not asking you to diagnose or say anything, but is that something that you need to take into consideration for people that are having those issues for HRT?
You need to take into consideration someone's entire health history. I would want to know, is that one kidney functioning fine, right? Because hormones are, and medications in general are metabolized in the liver, and then metabolites are excreted by the kidneys. If someone has abnormal kidney function, that's going to affect many drugs that we give, hormones potentially as well. But I'm not aware of having one normal functioning kidney as being an absolute contraindication. But again, I would look at that person's whole
Okay.
health history.
The theme that keeps coming up in all of this is it is very individualized
It
to
is.
every person. And I think what women tend to, boy, I'm broad generalizing now, but we're so used to the mindset is you get 10, 15 minutes with your doctor, you got to get it all in. And that is not the model. While working with a lot of menopause specialists now, this is an emerging occupation, I think, but MIDI is doing it very well in the model that they're using. Plus, you got research. For just a second, talk about the kind of research that MIDI is working on as well.
One thing that we are working on in terms of research is how we incorporate new and evolving medical research into our care protocols. So, if you are a large guiding organization in the United States, you often wait the 10 to 15 plus years for a randomized controlled trial to come out before you will make a public statement saying, we are changing our recommendations. What we have learned at MIDI is women don't want to wait that many years. They want an understanding of, I just read an article that showed me the importance of X, and I want to know, is there evidence for that? And does it apply to me? And should I try this? So we have all of our protocols are written in a way that I'm very proud of what we've developed because they are written in a way that they have all of the information that is consistent with large guiding organizations as it pertains to the use of hormones for a particular topic area. They have all of the information from large guiding organizations as it pertains to the use of non-hormonal prescription medications as it pertains to a topic area. Because we have people with integrative medicine training, naturopathic medicine training, we also have in that same document evidence-based use of integrative therapies, supplements, herbs, botanicals where it exists, and also defining where it doesn't exist. And then we have a way of taking this newly evolving information, rapidly incorporating it into those care protocols to allow our clinicians to do shared decision making. And that's what I think is really special. And that's something that I think has resonated with a lot of patients. So that's one way that we are using research. We are also internally starting to look at research. We have the largest database on women because we are the largest national provider of women's health care. I think we're currently seeing more than 30,000 women per week. And I think that gives us the responsibility to help answer some of the unanswered questions.
In my personal experience with MIDI, talking to the clinician, and I was taking, and when she was asking everything I was taking, every supplement, everything when we were doing the intake, and she said, "Oh, I was taking something called NAC." And she said, "Oh, I've not, okay, why are you taking that?" So, and she admitted to not knowing much about it. But then by the next appointment that we had, she knew about it.
Exactly.
But what was so refreshing was that first of all, she said, "I'm not aware of that," which is delightful to hear from somebody because we can't know it all. Nobody can know it all. No doctor, no healthcare provider, no one. So to be able to say that and then do the work on knowing that just tells me a lot right there in that one small instance.
Yeah, something we're trying to do. In terms of specific research, we are starting to look at some of our outcomes. In the past year, we've been able to show that when women come see us, we are increasing adherence to recommendations for mammogram screenings and colonoscopy screenings. So someone comes in to see us and says, I'm interested in hormone therapy. And we say, hey, are you up to date with all of your recommended cancer screening? If they're not, we put orders in to get them to get that recommended screening. We are starting to show improvements with our treatment plans on people's lipids and people's hemoglobin A1C. We see a number of people that come in with prediabetes, and we've had some early analysis showing that with our treatments, we are able to normalize people's blood sugars. This is still very early, and I would say our research efforts are still in the early stages. But me being an academic at heart, this is what I am so excited about. I am hoping that we are going to be the company that helps answer some of the unanswered questions. For example, is it truly safe for women with prior hormone-positive breast cancer to take hormone therapy? Does it increase the risk of recurrence? I am hoping that at some point in the future, we are able to help answer that and many other questions.
So many more. Well, let's keep going on ours. One listener wrote in, she was about to start her estradiol and stopped when she saw the inactive ingredients. Propylene, glycol, sodium lauryl, sulfate, methaparaben, which are things that we're generally told to avoid. So are there concerns? Is it, keeping it in context, or is it more benign than the wellness world has led us to believe?
So all medications have inert ingredients in them. For example, if you look at the different forms of patches, they all have inert ingredients that basically have to do with the matrix of the patch. And oral medications all have a variety of inert ingredients. Oftentimes it may help out with absorption. I'm not a pharmacologist,
Right.
but I think there is bigger concerns than there really needs to be. Now, that being said, people may have a side effect with one formulation over another. That is why one size doesn't fit all. We may recommend a certain form to start. For example, you have bad psoriasis. We may say, you know what, maybe a patch isn't right for you. Well, let's start you on a patch, but you have lots of skin sensitivities. If that starts causing a rash, we do want to change you to an oral formulation. So I think there's a little bit too much hype about inert ingredients because that's a function of how meds are made. But I do think you need to consider what formulation is right for what person.
Excellent. Okay, now really quickly before we move on, actually, we have many more questions about, as I'm looking at, where can cancer survivors specifically find credible information and resources specifically for sexual health after cancer treatment? Beyond MIDI, we know there's information
Please
there.
come to us. That was my
Yes.
main reason
Yes.
for joining
yes.
MIDI. I would say that there is lots of patient information that comes out through the National Comprehensive Cancer Network, the NCCN. I am very honored to have been on their inaugural survivorship protocol committee. I had chaired their menopause and sexual functioning committee, helped write guidelines. Those guidelines were more for practicing oncologists nationally, but they also put out patient guidelines. So
Excellent.
large organizations like the NCCN, ASCO, American Society of Clinical Oncology, also a great resource for information. There's also advocacy groups out there that are trying to get information. They put out information as well as oftentimes do courses. So I tell people, do a little search for yourself, looking for menopause advocacy groups, I need to come up with the names to tell you different organizations, but and also organizations like NCCN and ASCO.
Excellent. Excellent. We're hearing a little bit about the patch shortage.
Yes.
Yeah.
So realizing the reason why the patch shortage has likely come about is removal of the black box warning. So when the black box warning came off last November, lots of publicity about hormones in general, lot more women asking their providers about it, and a lot more prescriptions happening. And pharma did not keep up with the demand. I think that from what we have seen, that recently it seems like it's easing up a bit, but there are many pharmacies that carry certain doses, not other doses. We oftentimes have to send to different pharmacies than the patient typically uses. So it has become a little bit of a hassle. And my hope is that pharma will keep up with the demand, because I don't think the demand is going to go away. If you look right now, the statistics are that only 5% of eligible women use hormone therapy across the United States. I think the next time there's a large analysis of that, I predict the numbers are going to be increasing with removal of the black box warning.
Do you think that right now, after the removal of the black box and that percentage of 5%, Do you think that this is going to like a physician problem? Is this a patient problem? Is this a policy problem? Like, how do you see it going? Do you think more women are going to start using it because they are going to their physicians or they're going to a MIDI or they're going places and that's going to increase it? Like, how do you see that?
That's a great question. I think it's going to be multi-pronged. I think one thing that's going to happen is we're going to see more menopause training happening in medical education across the country. Right now, it's been dismal. So that will help. I think that's going to happen across OBGYN. It's likely going to happen across primary care, internal medicine, family practice. So I think we're going to start finally seeing people trained in menopause. And so one of the things that has been limiting is right now, if you are a woman going to your physician, there's a good chance that the physician's going to say the risk of hormones outweigh the benefits, just suffer with the side effects and deal with this. And I think that that will change at some point. Medicine is changing. MIDI is not the only digital health company that's out there. You see every day there's new digital health companies coming out. People are accessing medicine in different ways than they did previously, and in ways that increase access and allow people who otherwise couldn't reach their providers to be able to reach a provider. So I think the expansion of digital health will help increase, not just in this field, but in many fields. I do think that pharma needs to catch up because I think the demand is going to be there. But I think it's really multifactorial of how we see this changing over the next few years.
Do you see medical schools start initiating almost women's wellness programs, almost like you want to go into orthopedics, you want to go, where maybe if this is what you want to do, there's going to be programs or there's going to be places where they can do their residency for that specific choice?
That is an unknown. And in my experience, sometimes in medicine, it takes a while for change to happen. Will there be fellowships? And are there fellowships? Yes. Are oftentimes these fellowship non-CME, so they're non-formally accredited. Like within OBGYN, we have formal fellowships in maternal fetal medicine, reproductive endocrine and infertility, gyn onc. Are there going to be more and more sort of unique areas of these fellowships? Some exist. Will they expand and cover more topic areas? You mentioned wellness. To me, that includes the whole longevity space. So will there be longevity fellowships? Yes, I think all of that's going to change. Are they going to be formal fellowships where people can get board certified? That I predict will still take a while.
I joked once a long time ago, many years ago, that global warming was really being caused by the baby boomers all going through menopause and their temperature rates going up. I don't know that I was too far off on that, really, though, as we're right now, we're going to,
I like that theory.
right? Only 5% of us, at that time, there were only 5% taking advantage of any of this. So now maybe because of what you're doing, also global warming will start to retreat. So we can just solve the whole world.
Oh, wow. We're getting into a whole new subject.
We are. Hey, I want to ask one more question before we get into HRT discussion. So you talked about the woman who goes to the doctor who's saying, the risks outweigh the benefits, and that's old data, and right, they may not be keeping up for whatever reason. There's also women that are currently on older formulations or whose doctor just handed her a prescription without explaining the difference. What does she need to know right now?
That's a really good point that I think doesn't get discussed enough. If you are reaching 60, let's say, and you are on hormone therapy, my general approach is to change people to a non-oral formulation because risks of cardiovascular disease goes up with age. Cardiovascular disease meaning things like MI, stroke. Oral estrogen increase the risk of blood clots. Blood clots can correlate with stroke. So as people age, and particularly when we age, we oftentimes develop other cardiovascular risk factors. Our lipids go up, we develop prediabetes, diabetes, weight goes up. I will try to transition people to a non-oral form if they are on an oral. So I say that to say, not only is the initiation of hormones needs to be individualized, the continuation of hormones needs to be individualized and is nuanced. And just because you were started on one formulation at one point in time doesn't mean that's the formulation you're going to take forever. And so I really encourage people, this is a complex area. And you need to be seeing a menopause specialist, whether you want to see us at MIDI, I hope, or if you have a local menopause specialist that you can see. But people need to realize that it is not always a simple conversation. For some people it is, but for many people, there needs to be iteration. Some people don't respond to one formulation of hormones, and you need to try different formulations. That means you really need to know, you need to understand the ins and outs of different formulations of estrogen, different formulations of progestogens. We didn't even talk, I can't recall if we did at the first episode about the formulation of hormones called Duovi. Totally different formulation of hormones that includes an estrogen, and instead of a progestogen for uterine protection, it uses a cousin drug of the breast cancer drug tamoxifen. And it is being studied as a type of hormone therapy in women who are high risk for breast cancer, with the hope that it may be preventative for breast cancer. So we know drugs like tamoxifen. Tamoxifen is FDA approved for both treatment and prevention of breast cancer. Those drugs, tamoxifen, is in a class of drugs called SERMs, selective estrogen receptor modulators, and they act like estrogen in some tissue and unlike estrogen in other tissue. Tamoxifen happens to act like estrogen at the level of the uterus, and estrogen alone can increase the risk of uterine cancer. That is the entire reason when you take hormone therapy, you balance your estrogen with a progestogen. The progestogen component protects against uterine cancer. The SERM in Duovi doesn't increase uterine cancer risk, it prevents uterine cancer. And so this is a very specialized form of hormone therapy, but because it has a SERM in it, and the SERMs that are on the market are either treatments for breast cancer or prevention of breast cancer, and the estrogen that is in Duovi is the original estrogen that was studied in the WHI that was shown to be preventative for breast cancer, the oral conjugated equine estrogen. There's a lot of interest in whether Duovi could be preventative for breast cancer. And that, to me, highlights why this is such a nuanced conversation. If I have someone who's high risk, they have a family history of genetic mutation, I'm oftentimes going to talk about Duovi. My only wish is that it wasn't an oral estrogen and it had a non-oral estrogen and this SERM, but in the United States, the SERM that's in Duovi is not available on its own as an individual drug. It is only available in this combination with an oral estrogen. But my hope is we'll get new formulations of drugs like that. But that, I think, highlights, hopefully to your listeners, like why we need to individualize this field so much in terms of when we are counseling women.
Just such good information. I
Wow.
honestly, it's okay. Let's talk about testosterone. We opened the door to it in part 1, energy, cognition, muscle, mood, beyond libido. What's the evidence actually showing for women?
So the best evidence for testosterone is improving sexual functioning, and specifically low libido in postmenopausal women. No one's going to argue that. Large consensus statements put out. Expert groups got together, reviewed the evidence that exists, made public statements, publications saying there is good evidence for supporting for testosterone improving low libido in postmenopausal women. What we don't have is evidence showing it improves low libido as sexual functioning in premenopausal women. We have lots of premenopausal women who are interested in trying it. I try to say to them, look, we have FDA-approved drugs for low libido in premenopausal women, and we don't have the data on that in premenopausal women. Let's try you on something else first. We also do not yet have full evidence on the other areas like cognition, fatigue, muscle mass, bone health. We are getting more. There's evidence that testosterone improves bone density. We don't have fracture data for women. I like to think that's the area we're really going to get information sooner, is particularly with muscle mass and with bone health, because those are two big areas that menopausal women need to know about. Our risk of bone loss goes up after menopause. Women reach peak bone density at age 30. Everyone has a decline after that, with the most rapid rate of decline after menopause and the immediate years after menopause. Osteoporosis is a silent disease until someone falls and has a hip fracture. We know estrogen is preventative. That is on the labeling for preventing bone loss. But we need to learn a lot more about testosterone's effects on bone health. The other is muscle mass. There are women have a higher risk of sarcopenia after menopause, of low muscle mass. We know that there's a whole host of reasons. There is effects on metabolism. Estrogen has lots of effects on metabolism, on insulin sensitivity. We know that is also involved in muscle metabolism. We see higher rate. We know protein requirements go up for women. We see lots of women who aren't doing enough weight training exercise. They're not building muscle. They're not ingesting enough protein. And we need to have studies on whether things like testosterone could really help to supplement muscle mass in postmenopausal women. I don't think we're there. My hope is those are the two big areas, bone health and muscle mass, that we'll start seeing increasing data. I think the other ones, there's interest in it for improving overall well-being, fatigue, cognition. I think those are a little bit harder to study. But, my feeling is we need more evidence on the benefits of testosterone in women in general. What we do at MIDI is we routinely will talk to people about this is what the evidence shows. There is evidence to support using testosterone for improving low libido in postmenopausal women. Unfortunately, it is not FDA approved yet. Whole other thing I have heard, and my hope is that in the near future, in a number of years, hopefully we will have a testosterone formulation for women. But right now, it is not FDA approved, as well as testosterone is on a controlled substance list. There are a lot of hassles in getting testosterone for women. You need to be a DEA provider, that is DEA, Drug Enforcement Agency. So you need to have a specialized license to do that. Different states have different regulations for controlled substances. It is a hassle to get testosterone for women in general. But what we will tell our patients is if they are in a state where we prescribe testosterone, if they are interested in using it for one of these other areas, for muscle mass, for bone health, for cognition, fatigue, for improving overall well-being, we will be willing to offer it, explaining the caveats and what's known and what's not known. I get a lot of questions of should testosterone routinely be a part of hormone therapy? My own personal view is no, that we should be layering in. You start someone on their hormones, see how they do. Does it alleviate the symptoms that they came in with the first place, or what their goals were? If it doesn't, and they ask about could testosterone be added on for whatever reason that they want, absolutely, we should be having those individualized discussions.
Yeah, good information.
So kind of leading with the kind of last thing you said, I wanted to then go into, should a woman eligible for HRT, what is your take on using hormones and an SSRI together versus hormones alone?
So SSRIs, remember, are going to be first line for women with mood disorders, depression, anxiety. We see a lot of mood changes at the time of perimenopause and menopause. Menopause does not cause depression or anxiety, but if you are someone that is inherently susceptible to a mood disorder, a time period where that may happen is around the time of menopause. Oftentimes, when you are seeing a menopause specialist, if you are coming in with a mood complaint, we need to differentiate. Is it a mood disorder that should be treated with a mood stabilizer like an SSRI? Or is this really a broader menopausal issue that should be treated with hormone therapy? My general approach is you do not throw multiple drugs at someone at one time. If they have side effects, you don't know what's doing what. So, are there patients who end up on both drugs? Absolutely. You can see people that have menopausal symptoms and also end up having a mood disorder and needing a primary drug like an SSRI to treat their mood disorder. But if you're asking, should someone initially be started on both those drugs at the same time? I don't think so. I will tell you, we also use drugs like SSRIs for alternatives to hormones in breast cancer patients or other people who aren't good candidates for hormone therapy. So, off label use of some of the SSRIs, as well as there is one that is FDA approved as a non hormonal treatment of hot flashes. It's a low dose of Paxil. It's called Brisdil. It's a brilliant marketing ploy. Um, it's a lower dose than exists for depression, and so they changed the name so women don't have to think they're on an antidepressant, but it is the same drug, just in a lower dose. So yes, they can be used together if needed, but you really need to understand what's going on. And sometimes it's trial and error. You know, sometimes we're wrong. We think that someone's mood disorder or their mood complaints are related to more of their perimenopause or menopause symptomatology, and maybe we're wrong. We don't want to miss a mood disorder in general, but you know, because that's really serious, right? Depression and anxiety are very serious conditions, and you don't want to miss that. So, um, uh, bottom line is yes, they can be used together when needed, but my general approach would be not starting them together.
Okay, well, once again, you are showing us that MIDI has a very integrative approach to how you go about this, taking each patient's story, spending the time getting the background to properly take the steps to a diagnosis and what she should be on. So if
Yeah, and
people's
I'll point out that takes iteration, right? It
Yes.
isn't just one thing I want your listeners to realize is it's not, hey, come in one time and we're just going to give you your hormone prescription and go off and live
Right.
your life and don't ever see us. This takes time to iterate. It takes time to iterate on dose, on formulation, on figuring out just what you asked. Were we right? Are we missing something else that could be going on? Do we need to layer on other medications, whether that be testosterone, whether that be an SSRI or something else? So this is a process that takes time to really see how someone's symptomatology evolves, and also people develop other symptoms, right? We're living, breathing creatures that we change all the time. And sleep, that's another one. We see a lot of people coming in with sleep disorders, and we know that sleep is one of the most common complaints in perimenopause and menopause. We know that for many people, when you treat them with hormones, you will fix their sleep issues, but there's a percent of people that are not fixed by hormone therapy, and they may have other issues going on. They could have obstructive sleep apnea. Sleep apnea goes up after menopause. That is a risk factor for cardiovascular disease, something that is important not to miss. We also can see restless leg syndrome. And so if someone has a sleep problem, we put them on hormones to optimize their overall menopause symptomatology, but their sleep doesn't improve. That's something we need to continue evaluating to make sure we're not missing something like apnea or restless leg.
Yeah, you're building relationships with your patients so that you can walk with them in their care as they
Exactly.
discover themselves, right? You said something interesting about the marketing ploy and the fact that women don't want to be on an SSRI maybe or a certain type of drug. And, it kind of goes back to that root cause of shame and what we've been taught. And that's a whole nother discussion. But now we're going to add one more thing to all of this discussion because I'm hearing about this more now, and that is the ADHD diagnosis. Kind of
Yes.
coming in around the same, that adult ADHD diagnosis. What are you seeing with that at MIDI?
Your timing is perfect. We are actually in the process of updating our protocols in expanding out education about ADHD. There is an overlap with some of the symptomatology of ADHD and perimenopause and menopause. We see people coming in with concentration problems, with brain fog. That is a big overlap. And it can be difficult to sometimes figure out what is going on. Is this perimenopause? There are people that are being diagnosed with ADHD at the time of perimenopause. There is also evidence that says if you have an underlying diagnosis of ADHD, that your symptoms may worsen with the hormonal dysfunction that occurs during perimenopause. And so it is important if someone does have ADHD that they have a regular provider who is managing their ADHD that they can be checking in with for that management during this time period. And it's important for people like us as menopause experts to be able to differentiate. And again, that's where I was saying oftentimes it is trial and error. We need to be aware of the symptoms of ADHD. If someone has a previous diagnosis, we need to be educating them that it is possible your symptoms may get worse. With perimenopause, we need to ensure they have a provider that has been following them for ADHD. That is not something, we're not ADHD specialists. That requires specialized care, just like menopause requires specialized care. But I think there is increasing awareness about the overlap in symptoms, which is why there's a lot of confusion about that of is it perimenopause or is it ADHD?
Very good. Very good. Okay, we're going to add yet one more thing that
Or
is being-
another layered piece of the cake.
layered piece of the cake is GLP-1s, right?
Yes.
But the big question I want to ask there is women are saying, why am I suddenly needing a GLP-1 medication for my weight and an HRT for my hormones? What's actually happened biologically? Is it lifestyle, a food system that failed us? But underneath that question, women are asking, did I do this to myself?
So absolutely not. Now, that's not, across the board. Do people have eating disorders and disordered eating? Yes. But let's talk a little bit about what happens at perimenopause and menopause. Metabolism changes. Metabolism slows. With declining estrogen, it has marked metabolic effects on glucose metabolism, on insulin sensitivity. We do see weight gain go up. There's an average of 5 to 7 pounds of weight gain that happens during menopause. We see diabetes goes up, so blood sugars goes up. I said effects on insulin sensitivity, prediabetes, diabetes goes up. Those drugs, remember, came to market as diabetes drugs. So there are lots and lots of reasons that we start seeing weight change. On top of that, there's secondary things. If you are having lots of symptoms like hot flashes that are disrupting your sleep at night, That's going to make you more fatigued. There are studies that show people that are tired, fatigued, oftentimes aren't exercising. They don't make as healthy food choices. That can further increase the weight gain we see. So there's a whole bunch of reasons that can play into this, but this is not something that women are causing themselves. There are direct metabolic effects that have to do with the changing, with our declining hormones that happen during this time period in life. Now, the whole GLP conversation is absolutely fascinating because we have lots of data on them for diabetes and weight loss, but I think there's a lot of really interesting information coming out looking at the effects of GLPs on other things, on cancer incidence. There were recent studies that were presented at the American Society of Clinical Oncology. They were just, you can't say these are causal because these were database analysis, but they showed GLP use broadly associated with lower risks of breast cancer, colon cancer, lung cancer. Lung cancer is not a weight-related cancer. Lower incidence of metastatic disease, progression of disease. There are studies looking at GLPs for cognitive loss in Parkinson's dementia, lower risk of cardiovascular disease separate from weight loss. So all of these other areas, the thought is that these drugs work by decreasing cellular inflammation. And there's more and more that we are learning that inflammation is involved in disease, autoimmune disease, cancers, likely cognitive loss, so many different diseases. And so there is a lot of interest in how these drugs should be used separate from weight loss. That leads to the whole microdosing and what that means. And really it's finding the appropriate dose for the appropriate person. But I think we are still learning what are the benefits of GLPs separate from weight loss and cardiovascular disease on diseases as a whole.
So one of the things that I hear, I am not yet on a GLP-1 for my health. I've been asked to be, and I'm still contemplating. But the people that I do know that have been on it as a very small dose or for weight loss, one of their biggest things that are happening is hair loss. And a lot of people are saying, as you go through perimenopause and menopause, women lose hair. I mean, that's just a known thing, which we really haven't talked about. But they're finding that it's happening to them more frequently when they do that. Is there something that you can maybe talk about, or you've seen like a supplement or something that you can suggest to people that are having this issue?
So anyone who's having hair loss, I do recommend that should be evaluated because yes, we see that hormonal changes can be associated with hair loss. A lot of people notice changes in their hair texture, hair thinning during pregnancy, right? When your hormone levels are very different from non-pregnancy state. And it is a common complaint that you will see hair thinning and sometimes hair loss during the menopause transition. That being said, hair loss could also be a sign of other things. Thyroid disease. Thyroid disease controls our thyroid controls our overall metabolic health. And if your thyroid is off, that can cause hair loss. Ferritin. So that's involved in our blood counts, right? In our storage of blood cells. If your ferritin is off, that can sometimes be associated with the hair loss. There are too much hair also can sometimes indicate serious things, male hormone producing tumors. So hair changes, whether it's too much hair thinning, hair loss, don't just say this is just a normal part or even a side effect from a drug. That needs to be evaluated. If we think something is a side effect from a drug, we oftentimes stop the drug to see if the concern goes away. But it is a much bigger conversation. Are there things that can be used? Absolutely. We have a product that we actually created at MIDI that is a topical that contains many of the products that have been shown to be beneficial for hair loss. So minoxidil is one. It's been on the market for years. You can take it orally. You can use it topically. Finasteride, ketoconazole, which is in a topical shampoo. So we have combined a number of things in a topical that people may try. May work for some people, may not work for other people. Also, people can all see a dermatologist if they are shedding like large amounts of hair or having male pattern baldness. They should be seeing a dermatologist who specializes in this. So again, I oftentimes will tell people, don't just assume this is just a normal part of aging, or don't just assume this is a side effect of something you just started. Make sure you get it evaluated if it's a serious problem. If it's just like a mild little bit of thinning that someone's noted, absolutely, there are things that can be tried.
Good information. All right. We're hearing a lot on GLPs and muscle wasting. This has been almost to the point of like, I'm hearing of women who have talked to their doctors about it that say, nope, you're going to lose too much muscle. You talked a little bit about muscle, just in general, losing muscle at menopause and all of that, and needing more protein and all of those things. Layer that in with the GLP-1 discussion and
Yeah.
how concerning that actually is.
Again, I think we do know that is a potential side effect. What we know as side effects are more based on standard dosing of GLPs. And I think the big expansion in the field are people that are doing microdosing. And I don't think we have as good evidence on the side effects of microdosing of these meds. So I will just put that out there in general, because there are a lot of people that we are seeing that aren't candidates for the GLPs, so there are categories that were established based on on body mass index, BMI, there's a lot of problems with using BMI alone, but coverage for these drugs will be if you have a BMI of 30 or 27 with cardiovascular risk factors. But we see a lot of women in the perimenopause and menopause who don't have that BMI, have gained bothersome weight, have tried what they can to lose it, and are interested in lower doses of the GLPs. We are oftentimes prescribing that for our patients, but those lower doses, we have less evidence of, do you see as much of the muscle concerns, and we know a lot more with standard dosing. That being said, I already talked about that many women in the menopause develop low protein and sarcopenia. So if we put someone on a GLP, we need to be talking to them about their diet. We need to be going through how much protein are they taking in. There are many people who end up taking supplemental protein, whether that's in the form of protein shakes, or we review what their diet is like. So it's an important conversation that we should be having with anyone who is going on a GLP, to talk about these are the potential concerns. Mainly these concerns have been seen on people that are taking standard doses. We do have many people that are taking standard doses. We need to talk to them about their diet. How much protein? We need to talk to them about their exercise. Are they doing it multiple times a week? Are they getting strength training? Are they doing sufficient types of exercise to build muscle mass, to hopefully be helping build bone? So all of these are broader discussions and not just, hey, let's just give you a GLP because everyone's asking about it nowadays.
Yes, important. Any comment about the difference between compounded GLP versus, I guess,
Yeah.
what would you call it?
The
Standard?
Yeah. So the issue is that GLPs have also gone often on the FDA shortage list over the past few years. And as they were in short supply, compounded formulation was the only way for many people to obtain these medications. As well as there are a lot of people, as I just mentioned, who are interested in GLPs who may not meet criteria for standard GLPs that are going to be covered by insurance, and so they look to compounded formulations. The main issue with compounding is there are some snake oil salespeople out there. And when you are using a compounding pharmacy, you need to ensure that the pharmacy complies with all of the regulatory things that need to be done, third-party testing to assure purity and efficacy of the product. You need to know that the product you are getting has the drug in it, it is pure, and it is efficacious. At MIDI, we work with very specific compounding pharmacies that we have vetted for purity and efficacy, and make sure that they are compliant with all of the regulatory, with all of the regulations. I encourage people who are getting medications, whether it's a GLP or something else from a compounding pharmacy, to ask them. Ask them what sort of testing they do to make sure that they are getting it from an appropriate compounding pharmacy. I do think compounding provides an option for people that don't otherwise meet criteria. They're not going to get these drugs. It is oftentimes much more affordable way. So for most of us are cost conscious, and that may be a more affordable way to get that. So compounding shouldn't be thrown out broadly, but you just need to ensure that the compounding pharmacy has had third-party testing, it's been vetted, and you can assure that what you are getting is really what you're getting.
Excellent. Okay. Lisa knows that really everything is always all about me. So we're going to talk about me. I know this woman well, me. So I'm going to give you my profile. Hysterectomy in my 40s, kept my ovaries. So I don't know when my final period was. I don't know when I went into menopause. I don't know when that 10-year window is realistically, right? Cholesterol stable, started 10-year. I started my HRT past the 10-year mark through MIDI, did a GLP-1 through MIDI, compounding, only way I could do it, life-changing. I'm just going to say truly life-changing. Now I'm working with my cardiologist. I have a cardiac score of 14, cardiac calcium score of 14. My cardiologist, who really is lovely, but hasn't spent, more than collectively not a lot of time with me, wants me on statins, to which I'm refusing because I'm refusing. I had stable cholesterol for decades, which has really only started moving in the past 10 years. So probably very much menopausal, right? So being a woman in this situation and going straight to addressing the hormone root cause can change the picture entirely. And I did that, and I've taken all the steps. But ideally, for the woman kind of in the same position, how does she approach her cardiologist for this?
Remember that cardiovascular disease is the #1 cause of death, and there are known risk factors for cardiovascular disease, elevated lipids being one. Statins are the primary treatment for elevated lipids. Hormonal dysfunction and the loss of hormones during perimenopause and menopause definitely complicates the picture. But if someone develops hyperlipidemia, we are not going to say treat that with hormones or treat that with a GLP. I love the way that you have done this of layering things in, starting on hormones, adding a GLP. Our bodies change over time. That doesn't mean that someone can't develop hyperlipidemia despite being on hormones and doing all that they can, or despite being on a GLP. What I will tell people is see what happens. If you have done all you can, maybe we've adjusted dose to treat symptoms or see if it has a different impact on some of your metabolic profile. If your lipids are still going up and you have a specialist who is saying, hey, my recommendation is being on a statin, my recommendation is not to say, well, I'm going to ignore that and treat this with my hormones and my GLP-1. And again, I think it does speak to the whole fact that we change over time. Our health risks change over time. And when you get started on whatever you're started on, whether it's hormones, whether it's a GLP, whether it's one thing, you need to reassess your metabolic, your risk factors over time. You're always reassessing, like, are those medications achieving what you want them to achieve? But there are standard things that need to be assessed with time. Number one cause of death, cardiovascular disease. We always should be thinking about that in women. We always need to be checking cardiovascular risks, and there are plenty of people who need to be on other things like statins.
Well, and just to add to this, I didn't outright say no. I said, can we reassess in 6 months? And can I try some vitamin therapy? Can I look at some other options? Can I change diet? Can I do some of these things to see? So we are waiting. I will be interested to see what new blood tests have to say when I take them and have my follow-up appointment.
Yeah, and you're an educated person who is researching what can I do to help lower my lipids. I think it's different if you are someone who walked in and your first LDL is 200. We're not going to say, hey, try and use supplements or lifestyle or other things, berberine or, different things to try and lower your lipids. We're really going to be talking to you. So it's individualizing, looking at the overall picture, your overall risk for cardiovascular disease. Your CAC score isn't 0, but it's low, but it's still, you're in that zone where people are going to do this shared decision making and talk to you about what can you do to lower your risk further.
Absolutely.
Isn't there 2 other blood tests that are recommended for like cardiac? I don't know the name,
Yeah,
like
that-
LP.
Little a and B.
Yeah.
So those more are looking at the apoproteins or lipoproteins, or looking
Yes,
at
that's it.
genetic cardiovascular risk factors. If someone has an elevation in that, my understanding is we have drugs that are soon to hit the market, but right now, the only thing that someone could do is the traditional things, which is lowering their lipids. In the cardiovascular world, they are recommending people try and get their LDLs below 100. That doesn't, when you traditionally look at who gets recommended to be on a statin, oftentimes their LDL is much above 100. But in the cardiovascular world and the longevity world, people are now talking about trying to get the LDLs below 100. If you have one of those genetic markers right now, they will probably push you towards being on a statin and making sure your LDL is low. Again, my understanding is there may be some drugs that are soon to be on the market that target those specific markers.
Lisa just started a new exercise program. Talk to us about your
Did you have
regime.
to tell the world about that?
I did. I just told the world.
Tell us about it.
She's yeah, tell us about it, Lisa. No, it's a
Oh
great-
my
let-
God,
you're-
Katie.
You're happy
I
about
just
it.
love you.
I know you do. Well,
Okay.
I mean, I'm not giving away anything. You
I'm
exercise.
quiet, following the rules, doing the podcast, and from the mouth of babes, here we go. The funny part about that is I don't love exercise. I mean, I know I have to do it, but it doesn't give me that high and do all that stuff. But to be fair, I did start a training program with a trainer for strictly strength training because I know how important it is for my body, my brain, and my health at my age. So now that the word's out that I'm doing training,
I think that's awesome.
yeah, well, I mean, and it's funny because like I don't get all excited to go, but like I made times with this guy for 10 times in a row because I have to show up. That's how I have to operate. But it truly is important. And I know that bringing in more protein in your day is also very important at our age. And I'm trying really hard.
So the question is, what are the non-negotiables?
Yeah. So there's so many things about exercise that I think are many people don't realize. Yes, there are the people that get the high when they exercise. It is so important for us for maintaining bone health. There are specific guidelines that are out there for getting weight-bearing exercise at least 3 times a week, a minimum of 45 minutes each time to help maintain bone health. There is increasing data about strength training and the importance of that for women in menopause to help maintain their muscle mass and bone health. We didn't even touch upon the fact that there is data that regular exercise, specific amounts, 150 minutes a week, divided times, interval cardio, decreases the risk of breast cancer, decreases the risk of colon cancer, liver cancers, and others. You can potentially prevent cancer by ensuring that you are getting that amount of exercise. So it is important for so much of our health. In my mind, that is a non-negotiable. It is something that people have control of. I know it's difficult. I know there are a lot of people like, oh, I just don't like doing this. I try to encourage people, just put it in your routine. Think about it in the same way you do about brushing your teeth and combing your hair. Like, it is a part of your routine that you do. Whatever you're going to be doing, make sure you're moving.
Yeah, I mean, and that's what I had to put it in my calendar as if it was something for work, right? So I have to show up. And I am a walker. That is the one thing I've done consistently.
You
You
have.
know, I'll walk 3 to 7 miles,
That's
5
awesome.
days a week.
But the
But
truly
the training
strength
thing,
training, the
that's a
strength
tough one
training.
for me, and I'm doing it. Oh,
Yeah.
you should have seen me today. You wouldn't believe what I did.
See, look at
Way out of my
I'm
box.
giving you a round of applause.
Way out of my box.
So
Okay.
150 minutes a week, that is 2.5 hours in a
150
week, in
minutes
7 days.
Divided times interval cardio may decrease breast and colon cancers. Those are 2 very common cancers. Colon is on the rise. Like, it is something that people can do. For people who've had breast cancer, we have evidence that amount of exercise can, particularly in the setting of hormone-positive disease, can decrease risk of recurrence and potentially improve survival. Like, that's why I will tell people it is as important as popping a pill of whatever you are taking to include exercise in your overall treatment or your overall lifestyle, all of it.
And for some people, they might not be able to, it's not in their budget, right? They have families, they have this and they have that. And for me, I think to myself, you know what, then give up one thing that you would want to do, because exercise is actually more important than that.
And there's
But
so many things you
walking,
can find
there's things
online.
that-
Yes.
Yeah, no, that's
you know,
free, but I'm
there's-
saying the strength training, you're
Yeah,
going to have to buy
yeah,
weights. You might have to have
I
a
understand
program
that.
that you get on your phone. I mean, that
Yeah.
type of thing.
Yeah, no, I understand that. But that's why I think we always need to talk to people about what fits into their life, but set time aside to go out and take a walk. Just don't be sitting in front of your computer all day long.
Yeah.
Dr. Mindy, we're up against the clock with you.
Yeah.
We can't thank you enough. Join MIDI.com for more information. If anyone has any more questions, I'm going to ask if we can email you.
Of course.
Thank
I
you.
am always happy to talk to both of you. And
Thank
I
you.
so appreciate you asking me back a second time.
It's truly,
It's been amazing.
and hopefully life-changing for people, which is what we want. We are fortunate to have the platform to be able to do this. So thank you for joining us. Any last words?
First of all, thank you again for having me. The only thing I would say to your listeners is do not feel you have to suffer at this time of life. And if you aren't getting the answers that you are seeking, look elsewhere. Come to us at MIDI, look for other resources. But just if there's a question that you have and you feel like, I asked my doctor and I'm just not getting this answered, don't accept it. Continue to seek out care because we all deserve that.
Yeah. Fight for yourself.
Be your own advocate.
Be your own advocate. That's a much nicer way of putting it than fight for yourself.
And unfortunately, I think women are getting better, but they're learning how to be their own advocate. And I'm hoping that it continues.
Yeah.
We've got some pretty strong women in this world that are backing this whole thing. And I hope it keeps going.
I
hope the
literally-
momentum keeps going.
Yes, I literally have people that said they're sharing this podcast, the first podcast we did, and now probably this one, with their providers. They've had, many years of relationships with their doctors or whatnot. You get to be friends with them. They're sharing the podcast.
That's great.
So-
Well, I love what you're doing and raising awareness. So
Thank you.
keep doing it.
Thank you. Take care.
Okay. You too. Bye.
Bye, Mindy. I mean,
2 episodes and I'm still processing them both.
she's incredible. I mean, it's very unusual when you see a doctor of her caliber that has zero ego.
Right.
And still her whole goal is to make women better.
100% at all levels. So what I would say to our younger population listening, you're not too young. You're not overreacting. You're not alone.
Yeah.
And help exists. So go find it.
Right.
That's to our younger population who's going through all of this, who is hearing about ADHD and hearing about perimenopause and what does it actually mean. And, we're all on a daily march to, as we age, we're all on a daily march to somewhere.
Hopefully a long march. Hopefully a long march.
March. But we all are aging every day and it changes, just like the weather changes and goes through just so much, right? We as women, I spent so long after this was all coming out being pissed off about the lost years. And I've set that aside now. It's like the stages of grief. I've set that aside now. And I'm now embracing all the new knowledge.
Yeah. And hoping that, all the mistakes, I guess I made intentionally or unintentionally, I'm telling people, don't be me. Don't do what I did. Now there's so much more information out there. Listen, go to someone that will listen to you.
Yes. 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 And find somebody
And
who
you're not
doesn't have
going
that ego.
crazy.
Yeah, you are not going crazy. And you are, and you are responsible for your own health journey. So if you are up against a doctor who says no, and deep inside, you need to look for someone else, your fallback can be, or your first step can be MIDI. Join MIDI.com.
Yeah.
Or find a hormone specialist here in the Twin Cities.
Or anywhere
Do some
in the
research,
country,
or
whoever's
wherever you are.
listening.
Exactly. Because you're responsible for your own journey. And we're also, on this podcast, we always have been about being the best that you can be. And that requires inner work. And this is part of that inner work that you need to do. So,
But if you do a little bit of the inner work, your days get better. I can tell you by what
100%.
the decisions I've made in the last year and a half.
right.
And now that the whole world knows I'm working out again,
That's right.
I made that decision too.
But you chose to go a little further than I had wanted to, because it could have been a new it doesn't matter. Listen, we all need what you're doing, and bravo to you for taking those steps. And to be your best self, she's telling us, Dr. Mindy's telling us, but to be your best self, to be the woman in the mirror that looks at yourself and says, I am the best version of myself. You need to do the work, and you're doing the work. The answers exist. You need to be patient with yourself, give yourself grace, go out and find the answers and advocate for yourself, right?
Right.
And that's what this show is all about.
Yes, it is. And that is what Mindy has spent her career doing. And that is what we hope you take away with everybody today.
That's right. And the view in your mirror is worth fighting for. So go fight for it. If you want more information from us, theviewinyourmirror.com. And we love you and we thank you for being a part of this. And we're so proud to offer it. Until next time.